last lecture we have seen the facial nerve, that is the seventh cranial nerve, which is a nerve of a second bronchial arch. It is a mixed nerve and it is having both motor as well as sensory component. So it supplies the muscles of facial expression, then stylohead muscle as well as posterior belly of a digastric muscle, which are derived from the second bronchial arch. So it is having a spatial visceral efferent column of a functional component. Then it is also supplying the parasympathetic fibers that to the lacrimal gland as well as to the lacrimatory nucleus, then also submandibular and submandibular salivary gland or sublingual salivary gland through the general visceral efferent column, then general visceral afferent that is having carrying sensations through these glands through the column that is of a general visceral afferent column. Then it is also having spatial visceral afferent column, means it carries a sensation that is from the anterior two-third of a tongue to the nucleus of a tractus solitarius. It also carries the sensations from the face, proprioceptive sensations from the muscles of face as well as auricle, that is through the vagus nerve, auricular branch of vagus nerve, which is a communicating branch to the facial nerve towards the general somatic afferent column. So these are the 5 functional components. In last lecture we have seen. Then we have seen this nuclei of the facial nerve. First nucleus is the motor nucleus of the facial nerve. Again it is having ventral or dorsal parts which supply the different muscles of the face. Then it is having another nuclei, that is a lacrimatory nucleus, which carries the general sensory fibers towards this through the nervous intermediates to the lacrimal gland. Then next is the superior salivary. So this is a lacrimatory nucleus, this one is a superior salivary nucleus, and this is nothing but a motor nucleus of a facial nerve. These fibers turns in the pons just beneath the floor of fourth ventricle through the forming a genu, that is the internal genu around this sixth cranial nerve nuclei, and that emerge, that is the forming a motor root as well as sensory root from these lacrimal fibers as well as superior salivary fiber as well as the fibers, that is the taste sensations, which is going towards this nucleus of a tractus solitarius. Then general sensations are carried to this spinal nucleus of this trigeminal nerve. So this will be forming the sensory root, that is called the nervous intermediates, and motor root. Then it will enter into this internal acoustic meatus. So in the internal acoustic meatus it enter with this 8th cranial nerve. So it will passing along with the 8th cranial nerve into the internal acoustic meatus. Then it travels this canal which is present in this petrous part of a temporal bone, and there is a bending of this canal and it will enter into the middle ear cavity at the anterior superior part of a middle ear or medial wall of a middle ear, and it will bend here, and that is this canal is also called as a fallopian canal. So this is a genu, external genu of a facial nerve. This is the internal genu which is present in the brainstem, and this one is the external genu of the facial nerve. Then it traverses this middle ear cavity along this medial wall, that is the horizontal part of a fallopian canal or facial canal. Then it goes posteriorly and it will go downward vertically along the posterior wall of a middle ear, and here it enters or exit this middle ear cavity through the stylomastoid. This is a mastoid process, this one is the styloid process. In between that one foramina is there, that is called as stylomastoid foramina, and it will enter into the parotid gland through its posteromedial surface and come out at this anterior border. It gives the branches and that will come out through this anterior border of this parotid gland. So it gives 5 branches just like a crocodile feet, that is a temporal branch, then upper buccal, lower buccal, mandibular and cervical branches, and which supplies this all the muscles of facial expressions. So this is the motor fibers which supply the facial muscle. Then while passing through this genu, it will give just behind this there is a presence of a ganglion, that is called geniculate ganglion, which consists of a pseudo-unipolar cells. So here it gives one branch that is called as a greater petrosal nerve. This greater petrosal nerve, it will come in the middle cranial fossa, here it pierces this foramina lacerum, and in the foramina lacerum it communicates with another branch, that is a branch of this middle meningeal artery is present here, and the sympathetic plexus surrounding it, it will be forming this deep petrosal nerve, and that will be joined to form this nerve of a pterygoid canal, which will enter into this pterygopalatine fossa. So in the pterygopalatine fossa, this pterygopalatine ganglion is present. Okay. So in the medial cranial fossa, just over this anterior surface of the petrous part of a temporal bone, we have seen that there is the presence of this trigeminal ganglion, which is present in the trigeminal cave. And this trigeminal ganglion, it gives three divisions. One is the ophthalmic division, which will passing through the superior orbital fissures into the orbit. Then it will give this maxillary division, which goes anteriorly, and it will passing through this foramina rotundum and enters into the pterygopalatine fossa, and it will give branches to this orbit as well as maxilla. Okay. And third division, that is the mandibular division, which will come out through this foramina ovate, and after that is the mandibular division, it will relay in the ganglion, that is called as a otic ganglion, that will be discussed along with this ninth cranial nerve. Then this greater petrosal nerve, the fibers will relay into the pterygopalatine ganglion. This postganglionic fibers arising from this greater petrosal nerve, and that will join these branches of this maxillary nerve, that is the lacrimatory branches, frontolacrimal branch, and it will join with this branch of the ophthalmic division, because this ophthalmic division divides into three branches: frontal branch, nasociliary, and lacrimal branch. Okay. So this is the supply, that is the fibers arising from the lacrimatory nucleus, that will passing through the nervous intermediates. Then internal acoustic meatus go towards this fallopian canal. Then at the genu, the fibers enters into this branch, that is called as a greater petrosal nerve, which joins with the deep petrosal nerve, and it will forming a one nerve, that is called as a nerve of a pterygoid canal, which enters into the pterygopalatine fossa, and the fibers relay into the pterygopalatine ganglion, and postganglionic fibers arising from it joins with this branches of a maxillary nerve as well as ophthalmic division of a trigeminal nerve, and supply the lacrimal gland. So it will supply the lacrimal gland, that is a general visceral efferent, means it will cause the lacrimation, formation of a tear, that will be due to this lacrimatory nucleus of greater petrosal nerve. Then it will also give the branches to this during this canal, horizontal part, and this is the vertical part. Vertical part is present in the posterior wall of a middle ear cavity. Here this is the anterior wall of a middle ear cavity. You can see that due to this basal turn of cochlea, one elevation is there, that is called as a promontory. In that posterior wall, there is a one bony projection is there, and that is for this stapedius muscle, which is a small muscle which also arising from the second bronchial arch. So the fibers of stapedius supplied by this a branch of facial nerve, that is called as a stapedial branch. Okay. So it will give this branch, that is a stapedial branch. Then also it will give another branch, that is called as a chordotympanic branch. So there is another opening is there, which is present in the posterior wall, that is called as posterior canaliculum. So this chordotympanic nerve enters into the middle ear cavity through this posterior canaliculus. It will crosses this middle ear cavity and exit out through this anterior canaliculus. Then it will passing through this petrotympanic fissure, and it will join this branch of this mandibular nerve, that is a lingual nerve. Okay. So this is the lingual nerve, which carries the sensations from the anterior two-third of a tongue, and this chordotympanic nerve joins it, and it will supply this, and it will carry the taste sensations from the anterior two-third of a tongue. Then it will also give the branch to this submandibular salivary ganglia. So these are the preganglionic fibers which are arising from the superior salivatory nucleus which will passing through this chorda tympani and relay into the superior submandibular ganglion, and postganglionic fiber from this that will arise and that will supply this sublingual as well as submandibular salivary gland. So this is the this also gives branch to the soft palate as well as pharynx, that is the glands of the pharynx and soft palate. So this is all about that we have seen in the last lecture only, the course of the facial nerve. Today we will see the what is the applied anatomy of the facial nerve. So this facial nerve, it is having long course, so it may be injured at any places. So there are two types of injury of the facial nerve. One is the upper motor neuron and lower motor neuron. We have seen these nuclei which are present in the brainstem, and these nuclei are controlled by this. Yes, these nuclei are controlled by the fibers which are arising from the cortex, that is the corticonuclear fiber. So if you draw a diagram, these are the cerebral hemispheres are there. Okay, then here you can see that there is a midbrain, then pons and medulla oblongata. Okay, so here there is a presence of this facial nerve nuclei. This is the median plane. So this is the corticonuclear fibers which the nuclei are present in the cortex of the cerebrum, and that will enter or that will relay inside this facial nerve nuclei, and these nuclei relay contralaterally, or they control contralateral facial nerve nuclei, and this facial nerve nuclei give rise to the facial nerve. So the nuclear fibers which are arising from the cerebral cortex, that is the neurons which are present in the cerebral cortex towards the facial nuclei, that are called as the upper motor neuron. So if there is injury to these fibers, then that is called the upper motor neuron paralysis, and beyond that, that is the lower motor neuron paralysis. And also nuclear vision means also included in the lower motor neuron paralysis. So we have seen that the facial nerve is having various nuclei. Nucleus of tractus solitarius which carries the taste sensation, then it also having the superior salivatory nucleus which affect the saliva secretions from the sublingual as well as submandibular salivary gland, as well as palatine glands also supplied by this facial nerve, as well as lacrimal gland is also supplied by this facial nerve. So all these nuclei, if the lesion occurs at this level also, that will causing the lower motor neuron type of a paralysis. So this will control this face. Suppose these are the face is there, and this is the midline, and here you can see that there are two eyes, and this is the nose, and this one is the mouth. Okay. So this ipsilateral facial nerve or nuclei will be supplied both of this, or upper part as well as lower part of this face, but the control is of a bilateral control is of a facial nerve from the corticonuclear fibers, that is in the lower part only, upper part having the contralateral control. Okay, so when there is upper motor neuron lesion, there is a paralysis of this lower part of the face, but escape of this upper part of the face, that is the forehead wrinkles will be present in this upper motor neuron paralysis, and there will be a contralateral paralysis of this facial lower motor neuron, that is of a bilateral control is of a facial nerve from the corticonuclear fibers, that is in the lower part only, upper part having the contralateral control. Okay, so when there is upper motor neuron lesion, there is a paralysis of this lower part of the face, but escape of this upper part of the face, that is the forehead wrinkles will be present in this upper motor neuron paralysis, and there will be a contralateral paralysis of this facial lower motor neuron, that is so this is upper motor neuron lesion. Then next is the lower motor neuron, that is from the nuclei, then through the internal acoustic meatus, through this fallopian canal, Then when there is an injury to the nerve at this and exit point, that is at the stalomastoid foramen. So what are the causes? It may be idiopathic, it may be in the intracerebral causes in the brainstem, or that is due to the CVA, that is cerebrovascular accident, will causes the compression of that nerve. Then also if there is any tumor, that will also affect this cranial nerve. Nuclear compresses the cranial nerve. Then the nerve may be compressed at the internal acoustic meatus. So it may compress this. Along with this compression of this facial nerve, there are the compression of this vestibulocochlear nerve. So it will causes the deafness also along with this facial nerve palsy. Then if the injuries occur at this geniculate ganglion, the most common infection is the herpes zoster infection that occurs here at the geniculate ganglion. So there will be a hampering of this function of this greater petrosal nerve, which will carry the sensations or secretomotor fibers to the lacrimal gland. Means there is absence of a tear will occur, that is through the injury at the geniculate level. If there is an injury in the vertical part, just before this branch, that is the stapedial branch, then there will be a hampering of this muscles, that is the stapedius muscle, which will cause the hyperacusis. Then if you go downward, there is another branch that is called as a cauda tympanic branch, and that will carry the taste sensations from the anterior two-third of a tongue, as well as it carries the fibers that will go towards this gland, that is the secretomotor fibers to the sublingual and submandibular salivary gland. So if the injuries occur at this level, there will be a hyperacusis, as well as this cauda tympani also get injured. So there is the absence of this salivation, as well as taste sensations will be hampered. Then if the injury occurred at this level, that is the exit of this facial nerve, that is at the stalomastoid foramina, the terminal branches which will supply all the facial muscles. Okay, that will be also causing the paralysis of the all facial muscles. So these are the sites of the injury of the facial nerve and the causes of injury at the facial nerve. So one may be the cerebrovascular accident. Then if there is any tumor, that are the chances of the facial nerve injury. If there is any injury, means if the nerve is cut at the site of internal acoustic meatus, in this fallopian canal, at the vertical part before this giving branch to the stapedius, and at the stalomastoid foramen. So after emerging from this, it will supply all the facial muscles of expression. So upper temporal branch will be supplying the frontalis muscle, then upper buccal, lower buccal, then mandibular branch and cervical branch. All these supply the muscles of facial expression. So that will be, yes, if this injury is present at this level, it will be paralysis of all the facial muscles, which will supplied by this all the 5 branches of this facial nerve. So this is all about this causes and the effects of this facial nerve palsy. So if the injury is at the lower level, that is from the nuclei, so here we have seen that abducens nuclei lies in close relation with the facial nerve. So when there is an injury to this facial nerve nuclei, there are the chances of the injury to this abducens nerve nuclei, which will abducens nerve supplies the lateral rectus muscle. So it will produce, if there is involvement of 6th cranial nerve nuclei, it will produce as a lateral squint. Then if there is an injury to this lacrimetry as well as superior salivatory nucleus, it will causes the decreased secretion of a salivary gland as well as lacrimal glands. Means there will be a dryness of ear due to absence of this tear. Then it will carries the taste sensations towards this, toward the nucleus of a tractus solitarius. So that will be also hampered in this facial nerve palsy, and it will also carry the general sensation to this spinal nucleus of a trigeminal nerve. Okay, so this is spinal nucleus of a trigeminal nerve. So it will be also affecting this spinal nucleus of a trigeminal nerve, and general sensations will be hampered. So during this, there are the again causes are any injury, any trauma, vascular trauma, or if there is any infection, that is a most common viral infection is there, that is a herpes zoster infection. So in this herpes zoster infection mainly affect this geniculate ganglion. So this geniculate ganglion consists of a pseudo unipolar cells. So these peripheral processes are coming from this auricular branch of a vagus nerve, that is having communicating branch to it. Then it also carries the sensations from the proprioceptive sensations, and these central processes will go and relay into this spinal ganglion of a trigeminal nerve. So these are the upper motor causes of upper motor as well as lower motor neuron paralysis. So what happened in the lower motor neuron paralysis, that is called as a Bell's palsy. So what are the features of a Bell's palsy? So all the muscles will be paralyzed which are supplied by the fascia. So there is absence of wrinkles over the forehead. There is absence of all these muscles of facial expression. There is a drooping of a nasolabial fold, become flat, and drooping of a saliva from the mouth due to this paralysis of a buccinator and all these muscles. Okay. Then there is absence of a tear due to paralysis of this or due to injury to this. Now, so there is a dryness of a ear. Then there is also injury to this rectus muscle, that is the lateral rectus of eyeball, through this involvement of this abducent cranial nerve. It will also involve this eighth cranial nerve. So there will be a squint will be there, that is a lateral squint. Then there will be a deafness. If there is an injury to this nerve to stapedius, there will be a causing a hyperacusis. These are the various symptoms of Bell's palsy. So all the facial expressions are lost. There is the absence of wrinkle, nasolabial fold will be disappear. There is a dribbling of saliva. The patient can't hold this bolus in the mouth. There will be a dribbling of this bolus also and saliva also. So these are the features of Bell's palsy. Then what is the treatment for this Bell's palsy? So 60% or 60 to 80% of Bell's palsy will be recovered on its own. Okay. So you have to give, that is the physiotherapy main. And if the cause is a viral, you can add an antiviral drug. That is a acyclovir. So this is about the Bell's palsy. Then two syndromes are there, that is the Miller-Gubler syndrome, and there is also Ramsay-Hunt syndrome. So this, what is that Miller-Gubler syndrome? That is the injury to this facial nerve nuclei in the pons. So, and due to this pontine hemorrhage. Okay. So there are the chances of the injury to the sixth cranial nerve. Okay. So this is the Miller-Gubler syndrome. And second syndrome, that is if there is a involvement of a geniculate ganglion by this virus, that is called as a Ramsay-Hunt syndrome. So in that Ramsay-Hunt syndrome, this geniculate ganglion will be affected, and it will be forming a blisters over the skin which are very painful, then blisters over the auricle, then also it will cause as a otitis media. That is due to the viral infection, and this is due to the pontine hemorrhage. And one more term is there. What is that? Bell's phenomena. Bell's palsy is different and Bell's phenomena. When we ask the patient to close his eyes, there is a uprolling of this eyeball, and that is called as a Bell's phenomena. So this is all about the today's lecture, that is the injury to or clinical aspect of the facial. We have seen the facial nerve paralysis. There are two types of facial nerve paralysis. One is the upper motor neuron and second is the lower motor neuron. What is upper motor neuron? That is a corticonuclear fibers. Suppose this is a pontomedullary junction where this facial nerve nuclei present, and this is the cerebral cortex. Okay, so from this cerebrum, these fibers, that is the corticonuclear fibers which control this facial nerve nuclei are arising. Okay, so this is a facial nerve nucleus. Suppose this is a face. Okay, and this is the eye or orbit, then this is the nose, and this one is the mouth. Okay, so this is a central line, and this is a right half, and this one is the left half. So the fibers which control, which passing from the cerebrum to the towards this facial nerve nuclei, that are called as a corticonuclear fibers. Corticonuclear fiber. So these fibers arising from this upper part of our facial nerve nuclei supplies the upper part of a face. Means it supplies the frontalis muscle, orbicularis oculi muscle, that will be responsible for the closure of eye. And fibers arising from this lower part of this nucleus supply the middle and lower part of the face, that is the cheek and the mouth, that is the levator anguli oris as well as buccinator muscle. So this, if the injury is lower motor neuron, that is beyond this the cranial nerve nuclei throughout the course of this facial nerve, then that is called a lower motor neuron paralysis. In that, whole side of this face will be paralyzed. Means if the right side injury is there, right half of the whole face, right from the frontal forehead or frontalis muscle, then orbicularis oculi muscle, and all the muscles of this right side will be injured, and that will be paralyzed. So that is called as a lower motor neuron paralysis. What happened in upper motor neuron paralysis? That is the corticonuclear fibers. This corticonuclear fibers, it will cross and it will control this opposite on this upper part of a face, means frontalis and this orbicularis oculi. Suppose there is an injury to this upper motor neuron, what happened? So these fibers will be coming from the contralateral side, and if there is an injury to this left side of this upper motor neuron, there is a corticonuclear fiber, so there will be a lower half of this face will be paralyzed and upper half will be escaped, because it is having bilateral cortical control, that is from the right side as well as left side. So there is a presence of horizontal wrinkle and elevation of eyebrow is possible in this upper motor neuron lead. So that is the main difference between the upper motor and lower motor neuron. In upper motor neuron, the upper part of forehead or face will be escaped, while the lower part will be get paralyzed. And we have seen this lower motor neuron paralysis, there is absence of wrinkles, there is absence of elevation of this eyebrows, then there will be a obliteration of this nasolabial fold, as well as there is a drooping of this saliva from this mouth, because there is a paralysis of orbicularis ori, as well as drooping of this lips or mouth toward deviated, and that is due to the paralysis of levator oris muscle. Then there will be a absence of this tear, which will cause as the dryness of eye. Okay, and we have seen the few this syndrome, that is a Ramsay-Hunt syndrome. That is due to the infection, that is a herpes zoster infection of this facial nerve at the geniculate ganglia. Then we have seen this Willard-Buehler syndrome. That is a pontine hemorrhage or pontine injury. In that, contralateral hemiplegia along with the facial palsy will be there. So this is there is absence of this salivation due to this injury to this fibers, which supply the secretomotor fibers to this salivary glands. Then also there is so this lower motor neuron, we will see that it is also called as a Bell's palsy. So this injury right from the nuclear level, that is through the whole course of this facial nerve. So this is all about this facial nerve paralysis or injuries of the facial nerve. Thank you.